his way here, so he's just running a little bit late. So what we thought we might do this morning is just give you a bit of an update on bowel screening. You'll recall a presentation some time ago where we discussed about looking at bowel screening for Tairāwhiti, and we are now close to go live with a go live date of next week. So we've got the team here. So Samir's our clinical lead. He's a general surgeon at Hauora Tairāwhiti. Keith Cordner is the project manager for the bowel screening implementation. Sue Egan-Cunningham has taken on the role as coordinator for endoscopy practices and will be the lead clinical nurse for bowel screening. Roy Martin has joined the team with health promotion and is an extremely valuable link to our coastal community. Tony is our champion communications person, so part of the presentation today will be some of the videos and the promotional videos, which I think the board will enjoy watching and seeing how the approach that we're taking. And Ppe is our co-master for the program. I'm going to start by handing over to Samir, and he'll just give you a bit of a discussion about what bowel screening is for, what its aim is.
Good morning. So it's a big topic for me to briefly cover in a few minutes. But bowel cancer is it's a common cancer. It's the second most common cause of cancer death overall in both sexes in New Zealand for men and women. And generally, it's a cancer of advancing age. So you've got a 1 in 200 chance of having a bowel cancer if you have a colonoscopy at any given time. And if you're 70, you get about a 1 in 20 chance of having a bowel cancer in a year. So it's definitely becomes more prevalent as you get older. And what we do know, and it's been known for a long time through randomised controlled trials around the world, is that the vast majority of bowel cancer starts from a small polyp which grows over 5 years into a cancer. So, and if you remove those polyps, you decrease the chance of getting cancer, of getting a bowel cancer. We also know that if you get bowel cancer in its early stages, that it's very curable just with an operation alone. So both of those aspects of bowel cancer make it a very preventable or disease, or even if you get the bowel cancer, if you get it at an early stage, you can make a big difference on someone's life expectancy. So around the world, there have been screening programs in place since the 1980s. In Europe, they were doing it in the 1980s, and New Zealand's just getting on board over the last couple of years. And there are different ways to screen for bowel cancer. You can use colonoscopy, which is a very expensive way, because that means everyone gets a colonoscopy every couple of years. And we've opted for the FIT test, the fecal immunochemical test, which is a test which detects microscopic amounts of blood in your stool. And the way the bowel screening program will work is that patients will be mailed out these tests every 2 years from the age of 60 to 75, around the time of their birthday. And asked to dip it and send it. And if you've got a positive result, you then get a colonoscopy, or you're then offered a colonoscopy. And if you have a colonoscopy and you've got a positive test, you've got about a 70% chance of having an advanced polyp and about a 7% chance of having bowel cancer. So, a positive test is something that needs to be actioned. And we've been rolling this, it's been rolled out over the country over the last couple of years. We're about the second last cohort to get it. Yeah, we looked at to get it. And we are approaching the rollout in a slightly different way because of our population, which will be discussed shortly, I think.
So great, awesome to hear that for the background. Further to that, we discussed with our community what would work, what wouldn't work, and the feedback was pretty loud and clear that for our priority population receiving a letter in the post and voting to join the program wasn't going to work. So that was clear from the get-go. So we're the first DHB in New Zealand to trial the community by community approach, and I'd really like to take a moment to thank the ministry for giving us that chance and opportunity to do things slightly different. So what we've done is engage with our community partners, in particular with Hauora, Tairāwhiti Health, and Ppe, which is our Pacific Island Community Trust team here within our DHB, to look at how we can approach this differently. Our vision is that we will have kaiwhina, we have some health workers actually going into the homes of the people that are eligible in our priority population to participate in the program. So that's a unique challenge for us, but one that has been welcomed by all, and we're really looking forward to trialling this initiative within our Pacific Island community and then rolling it out further over the next 2 years of the program in its initial first 2-year phase. From other firsts for us, because we like to be the first place in New Zealand for a lot of things, we're also trying the, well not trying, but implementing a new bowel screening register. So that's a high-tech system that's going to keep all the patient demographic data in a centralised storage facility. All our clinical information will be fed into that, and it's going to provide an opportunity for us to ensure that what we're doing well, and it meets all the quality parameters of the program. We've also got probation, which is also a data repository mainly utilised for the clinicians. It's a tool in which we can take photos, we can provide information on the histology that is provided once the polyps have been tested, and it also is a information store in which we can also utilise that information to look at what has our community had, what has been detected, what have we done to ensure that those patients have received the optimum treatment possible. So yeah, it's been busy 18 months, and we've really embraced the challenge and couldn't have done it without the amazing team of support around us. We are just one of a huge team that has been there, and I can't speak highly of them. We've had support from our regional bowel screening partners as well as the national team at the ministry. And yeah, we're ultimately working towards ensuring that this program has a really high uptake and to ensure that the rates of bowel cancer in our community are detected at an early stage so that we can intervene and make sure that our patients' chance of dying of this preventable disease are minimal.
I want to ask Sue to talk a little bit about endoscopy because Tony's going to show us one of the videos, so you don't end up with.
So just to give you a little bit of an idea, we sort of understand while the idea of having bowel screen is fabulous, that the idea of actually, you know, doing the test, you know, is not something everybody really loves, and especially in our predominantly Māori community. And I'm sure I've been working with both the communications and media work stream, but also really closely with the equity group, and they actually just before I came back, they had some fabulous sessions where they really got the lowdown on what's going to work and what's not going to work, as Kath was saying. That's where we community. So we realised that we perhaps needed to take a little bit of a different route when it came to trying to get the message across. And we're so fortunate we've had an amazing group of people who've come on board to be our champions and have told their stories, telling their messages. So I'm going to show hopefully the first video. Our first champion is Roger Faber, who's going through bowel cancer journey at the moment, and he's been very supportive in telling his story.
I can remember the actual time I was at the terrier racing and I had to go to the toilet and noticed that there was blood on the toilet paper. That was the first time. So I went to the doctor and they did a prostate check, PSA check, basically said that those were all clear. And about halfway through last year, I noticed that the blood was getting a bit more intense and I was having bowel movement problems where the odd times when I needed to go at pace and get to a toilet. So I decided it's time to go back to the doctor and told them the symptoms. They basically did the same checks and said those were all clear. but said really the only way to tell 100% is have a colonoscopy, and the surgeon came out and basically said, you've got bowel cancer. The one thing that was surprising, they told me that I'd probably had bowel cancer for 7 to 10 years, and I was just lucky that I was not overweight, fairly fit. I love my sports, I still play my sports, tennis and soccer, and don't smoke, and that was probably the reason that it hadn't grown too much, and they were able to work on it. But yeah, it was just a matter of, hey, this is what's happened, right, I've got to deal with it and deal with it the best way that surgeons, etc., recommend. I'm really happy to tell my story to anybody that wants to listen, and I have told a lot of people, because it's amazing how many guys do have little problems and don't go to the doctor. I was at a carpet court conference and talking to a whole lot of guys there about it, and one of the guys, who's a manager of another store, sort of said to me on the side afterwards, he said, oh, I've had a couple of those symptoms, and yeah, he was younger, he was 56, and he decided to go and have a colonoscopy, and he actually did find that he was at the very early stages of bowel cancer. He's been treated and he's all clear and gone forward, and he regularly rings me up and thanks me very much for that little chat we did have. So yeah, the big thing is, yeah, if you think something's wrong, act on it. Don't be too proud to go to the doctor and tell all those symptoms.
So just, Roger actually rang me the other day, he's had his photo in the newspaper and a couple of ads. He says he's already had 5 people come and talk to him about that they've got bowel cancer and how they're coping with it, and 2 others that, or 3 that had had bowel cancer and want to talk to him, and 2 others that said they had symptoms, and what should they do? You know, should they go to the doctor, or am I just being silly? So, yeah, I mean, let's hope that the champion approach is going to work.
Oh, so you kind of just talk a little bit about colonoscopy and the colonoscopy and what we get
So yes, I'm Sue Egan Cunningham, the endoscopy facilities coordinator. I've been involved in the endoscopy pathway for quite some time now, but we've just added to it and put bowel screening in there. So just like Roger said, we have those that are symptomatic, and bowel screening is for those that aren't symptomatic. In order to go live with bowel screening, rolling it out, we needed to meet time frames. So we've got our different categories. We've got our urgents, which are our very high suspicion of cancers. They must have a scope within 14 days. We've got our semi-urgents, which must have a scope within 42 days, and then our surveillance, which will see the scope within the time frame allocated by the MOH time frames. Just like to say, we are agreeing at the moment, and we are meeting our time frames, which is fantastic. We're constantly doing measures on patients with this bowel screening rollout. It's enabled us to put a whole bundle of order processes in place. We're doing patient satisfaction surveys regularly. We're constantly checking patients' comfort scores. We're always trying to get feedback from patients to do that, how we can improve our processes.
Tony, are we ready to?
Yes, I think so. Let's try. No, I think it's my screen again. Maybe actually Jenna could talk a little bit about, Roy Martin could talk a little bit about, and I'll show Jenna. Yeah.
Kia ora tātou, tai toko ngā kōrero, koro mai kau te atanei. So I've been really privileged actually to be a part of working with this fabulous team, and as you well could imagine, it's dear to me because I was raised in Ruatoiti with my grandparents, so I know my community, I know my whānau, and we knew from the start that the way the bowel screening was going to roll out would not work in our community. So it's been an awesome journey and positively resolved. And I'm grateful for Uncle here and our Ppe Requirements also who guide me in the work that I do as well. So for me, we, the Cancer Society, I've been Cancer Society's health promoter for 19 months now. And this is actually fitted in really quite nicely for myself, my work, and we have a signature program called Tairāwhiti, whereby we'll travel to Marae, and I'm fortunate that with this huge takeover happening right now, we're able to have the expertise of your team here to travel with us. So the Cancer Society, Hauora Tairāwhiti and Tirana Health, and work closely with Ngāti Hauora, will travel to each marae. We're starting up in Hinerupe and Tairāwhiti. We'll then travel to Ruatoria and then to Whangarā this year, and next year, our plan, beginning of next year, will be to start this in Muriwai, Patitahi, and then again in Matawai, to go to our marae, travel to our marae, where we know that the whānau will come to listen to Wana and learn about cancer, in particular this bowel cancer. And so the National Bowel Screening Program will be carried out through the marae, starting at the top end. So I believe, well, I have been informed that Ngāti Hauora will start in the top end at Matakawa in the top region. And so we'll be travelling with the Hauora teams, as well as the hospice, palliative care, Cancer Society support team, and your staff here, providing they get the okay by the board, to talk with whānau and discussing wānanga, what is cancer. And each of the teams will just share a little bit about their roles, their expertise, and build those relationships with our whānau, because as you know, it's all about relationships. And when whānau will meet the team, it just makes them feel a little more comfortable and, okay, it's not so scary, I can do this. And it just gives them the confidence to take action, because for so long, as you know, we have the highest statistics in almost all cancers. And so I'm really passionate about seeing that our whānau can take positive steps and measures for their mokopuna. And also I've invited also the schools to attend, because I believe that it's the children that will be the key to sharing those, or encouraging their tupuna to take those positive steps to having the test. As you've heard from our colleagues before, it is a simple test, and with the whole team behind us and the iwi, I'm really positive that we'll get some better results and hopefully be able to cure cancer, stop cancer, inform our whānau to wānanga this kaupapa all about cancer. So I'm really excited and looking forward to this happening. Kia ora tātou.
So we've been really fortunate to have two superstars supporting the bowel screening rollout. And so I'm just going to show one of those two superstars now.
Karena mātou I rongo mo te rā momo mate, mo te mate puku puku nei. Wahi tina tiko o te tangata. E kia nei roto te reo Pākehā, ko te Bowel Cancer tērā. Anō nei te mea kia mātou, heka, no e nei rātunu nei tēnei mate. Ka tau mai ki roto ngā wahi pēnei. Kei te ngaua tātou, kei te tino ngaua tātou I ngā mate puku puku nei. Ko etahi o ngā tohu o tēnei mate nei, ka kite koe he toto kei roto tiko, mōhio koe he raru kei roto I a koe, me haere ke whakamātautia. Koe rā tētai. Ko tētai anō, ka rere kē te rere o tō tiko etahi wā, ka roa pērana, haere kia whakamātautau tia koe.
Ka rongo koe i te mamai, ka rongo koe i te ngau i tō puku. Koe rā tonu te wā, ka tīmata ki te whakamātautau. Nā reira, kaua e whakamā, he ngāwari noiho tēnei mahi.
Nō reira, e hara mai nei tau, hui mai nei tau ki te kāinga, ki te aki i o tātou whanaunga, kia kaha te haere, kia whakamātautau tia rātou, te rāpa kei roto i a rātou e tōa matera, e prau ana, e ngau ana. Engari, kare nuhe mō hiutia.
Kia tika, nā reira, ka hoki anō tātou ki ngā tohu, ki ngā mahi e o tātou mātua tīpuna. Hoki ki te māra, hoki ki te whakatōkai, me te noho, tahi ki te taiao. Ka rongo rātou i te mauri ora o te katoa o te tinana. Ka mau ki te wairua te hinengaro, hei whakahaere anō iaia i runga i tōna papa kāinga.
And that's a lovely introduction to Tairāwhiti, who's going to talk a little bit about his role and his support and his leadership of this kaupapa for
Tātou, tutahi, aroha mai ka reo kone, i te tīmata tana, e whai kōrero atu ki a koutou, e pohiri ati a koutou, roto i tōko i tō pūng. Ki rāke au i tērā o ngā whare, e te kāinga o tata Tairāwhiti ngata. I reira ki au, e awhiana e te whānau, me te mohi o tunu, a te rangi tonu nei, ka ngaro tu tērā i a tātou. No reira, koutou Tairāwhiti mā, koutou apiti hono, tātai hono, koutou kia koutou, haere tu rā koe, kia rātou ke reira, te tari maena, apiti hono, tātai hono, tātou ano, i nā koutou. It's difficult for me to talk about myself because that is the way that I've been brought up. You do the do and shut up. So it's hard, you know, to talk about the things you do. Let somebody else look and evaluate. Yeah. If you're doing fine, they'll say, ka pai tō mai. If you're not doing fine, hara mai kone, tīmatano. Come over here and start again. So it's difficult for me to talk about myself and the things that I do because I hold fast to a lot of the things that our tipuna taught us. And one very specific one is Kare kumara e kōrero mō tōna māngaro. I prefer to use that in any of you East Coast Māori, and that's all of you. If you use that quote, don't say Kare kumara e kōrero mō tōna reka. The proper quote is Kare kumara e kōrero mō tōna māngaro. Sorry, Lord, I'm going to have to spend a little bit of time here so that my East Coast people will go out there in Tokomaru and Tairāwhiti and say these quotes, and suddenly the pakeke heads will lift up. Oh, ka pai tērā kōrero. Okay? The kumara does not talk about its own sweetness. Kaore te kumara e kōrero mō tōna māngaro. The kumara does not get ripe until it has changed its color from white to yellow. And when the kumara has turned yellow, I think I've gone past yellow, I've gone, started to go brown. But when the kumara is yellow, that's when it is at its peak of sweetness. Okay. Kare te kumara. In other words, when the kumara has changed from white to yellow, the kumara has lost its whiteness. It's gone to yellow, and that's when it's sweet. Kia ora? I'll buy it. So, I am a person unfortunately, not much skill in the use of new technology. My technologies, so it's hugely important for us, Māori, for me to go home and carry my message, kanohi ki te kanohi. Through that way, I can read whether you're fibbing to me or whether you're telling the truth. Okay? Whether you're fibbing to me and telling the truth, and vice versa. So I need to go in amongst our people and spread the message that way, as you heard it over there. Koera te mea nui is to make our own people feel comfortable about getting going to be screened. There are far too many of us say, oh, ke te pai noho au. I'm okay. Especially our older people. The older we get, the more independent they want to be. And so this thing, got that buzzing sound in it. So it blocks out all the other noises and don't want to listen. We need to sort of get rid of that buzzing sound and open those ears up so that the message can get in. That, I feel, is my part in this. My nanny died in 1955. And she died, they say, of natural causes. I would rather have the corridor there died of bowel cancer. It will make me feel much happier, so we can look at those things that her mokopuna, her great-grand mokopuna, can look. Our great-grandmother died of this. I don't want to die of that and go elsewhere. Kia ora.
Kia ora.
Tēnā koutou.
Kia ora.
Kia ora tata.
While Taina may not want to talk about his own sweetness, I will make strong reference to the very beginning of the bowel screening program when we held a workshop, a hui, with people from the coast, and Taina was there along with lots of other representatives from the coast who made it really clear that the standard way of sending a letter out and asking people to put a sample of their tutai in an envelope and put it through the post was met with horror. And Papa Taina has kept us true to the kaupapa that we were not going to do that, because we knew that that would actually mean that we would not engage the people that are at most risk. So he's been an absolute champion and a strength for that. I also note his comment about family linkages, and the next video we'll show you is from somebody that you will recognise from this community, and the importance of family linkages. Have you got Tama?
Yeah.
Is that possible?
Before you do so, there's one hugely important person in amongst our community. You would have seen her on the video with me. You would have seen her on the video with me. It's very difficult to get her services at the moment because every other organisation wants to grab her. I think that's more, that's screening well really. We are fortunate we were able to, grab her for, because she's all over the place. I managed to get her for the launching of Mātai, which is supposed to be on the 7th of September.
Kia ora.
And just to let you know, we've got more of Papataina and Neri Queenie. That was the short version. We could, when we were videoing them, it wasn't like, trying to ask them some questions. It was a fabulous korero, and it really was a hard job to chop it out, which we have for the short one, but there's a much longer version that someone who doesn't speak Māori knew exactly that it was touching my heart. It was fabulous. But anyway, we've got Tama from Tairāwhiti Health, who's got a family.
Ko Takitimu Te Waka, ko Taranaki Te Maunga, ko Ngāti Tūkarangi Ngā Hapu, ko Taranaki Te Iwi, ko Te Hauora o Tūranganui a Kiwa Ngā Mahi Ana, kia ora koutou. I originally came to Tūranganui a Kiwa in the summer of '95. I was young and had no ties or no nothing and just played basketball for a few years, and then was lucky enough to pick up a job at Tairāwhiti Health. So this June I've been in Tairāwhiti Health for 20 years. We lived in a little small town called Opunaki on the coast of Taranaki, and when you go to the whānau Uripa, you can see lots of our uncles that passed away, but you can sort of go bowel cancer, some sort of cancer, bowel cancer. And my dad died when he was having an operation of his bowel cancer, and he got septicemia and he didn't wake up. My dad was, I wouldn't say he was fluent, but he sat on the pai, he went to the kura and helped out as the kaumātua. He was trying to get the rest of his siblings to step up and help out through the generations. So I suppose we've missed a lot of that. It's left a huge hole around role modelling, around our tikanga and our kawa. When you talk about symptoms and you talk about Māori male, you talk about older Māori male that don't really talk about those things too much. And when you go to the toilet, your bowel movements change or there's blood. They didn't really talk about that stuff. It wasn't until it was too late. I think that we need to be having those discussions more, especially if you can catch it early. Why would you not want to catch it early if you can?
So I hope I've been able to give you a bit of an oversight of where we're at with the bowel screening program. I want you to see the videos before they start to becoming part of our promotional activity. We go live on Monday. There isn't a great celebration. There isn't a big balloon blowing up or anything. We are just going to go live because this topic is whakamā. It is quiet. We don't want to put people off. We want to just take our time and work our way through it. We also have a vision for ourselves for the first 12 months, that if we're able to meet all of the standards and roll out bowel screening well, particularly for our priority populations, then we have had a commitment from the ministry that we will be able to extend the bowel screening age range for the people of Tairāwhiti, which means that we will be able to take that down to 50, and that's our goal. So we want to be able to look at that and move that forward and get towards that, because I think that will also make a difference. And thanks for the team to answer any questions. I know it's going to be a theatre, so if you've got any questions, just there, they might be taken quick. And otherwise, we'll leave you to the rest of your meeting.
Yeah, thanks for that. I'm not sure who I'm asking, but where do GPs sit in this? I mean, I'm of an age and I go to the GP and they've never said anything to me about bowel cancer, and they should have been actually saying it for 6 or 7 years. So when you tend to go to the GP, you're very single focused on what you've walked in the door for. What's happening in that space?
So the GPs absolutely have a role, and this will become the same as any of the other screening programs that your GPs have now on their system. So when you go and get your heart checked, bowel screening will be asked about. Have you received your kit? The screening program hasn't been something that the GPs have been promoting, and most of the time we are looking at symptomatic. So it would be that you've gone in and sort of said, I've got a bit of blood in my stool, and that's where the GPs would be responding to. They haven't had a tool for being able to screen up until now. We have had previous conversations that asking people if there's been any change in their bowel motions might be something that that they could have been doing, but as a community we're also doing it, and I know that's a strong message coming out of the Cancer Society. You know, when your normal's not your normal, go and get it checked. That's kind of that promotion around change that. The GPs absolutely have a role in the positive kits. So the screening kits come out nationally, they will be tested nationally, and then if there are positive results, then that will go back to the GPs. The GPs then have a responsibility to link with somebody with a positive kit and make sure that they're referred to the hospital. So that's where the key role of the GPs is, and it will now come up on your Manage My Health or any of the tools that we've got. You're due now, and the rollout is, it's based on your birthday year. So if you're born in an even year, then you're likely to be called up in the next 12 months. And it's, as Kat said, it's the birthday gift that we give to you around the month. So that's how they stagger it, so that we don't end up overwhelming the system by having too many people coming in at once. But the key messages are, when you get the kit to do it, and if you're normal, it's not your normal, get it checked.
And I know for myself, you know, because I'll be up there with the people, and that's something I have to do. Simply because if you go in a place promoting something like that, our people are going to ask that question of you. Have you done it?
Oh, sorry. Tony?
So what I was interested in knowing was the age. It's quite a high age, and you said it's going to potentially come down to 50. What were the sort of time frame that might come down to, and how optimistic are you that we can meet that? Because as soon as I saw the age, initially I thought, well, for this, that's just going to be way too late for most people.
And that's been the voice that your chief executive has definitely taken to the ministry many times, and is also being repeated in many forums, that the age range from 60 to 74 is late for a lot of people. So our time frame locally is that of the commitment is that if we can, within the first year, demonstrate that we're able to achieve and maintain our standards and maintain our throughput and not delay the system, then we'll be able to extend that age range in the following year.
Great. So as the DHB, we represented that through right to the Ministry of Health, and eventually got an agreement with the Director General that we would roll, as it's been described, we would roll out for the first 12 months, do our very best at making sure we try and get as much coverage as possible, as in the work that the team has done to do that. And then after 12 months, we would extend.
Great. Thanks, John.
Thank you for that presentation, and you answered my 2 questions in your last sentence. How long is the trial, and why aren't we starting at a lower age? And I think that should be in your 3 points, Kat, that should be one of the high points for all the reasons that we've talked about. So good luck, and happy to promote kaupapa on the coast.
I just had one question. I was really curious around why bowel cancer was so high for Māori, and whether in your wānanga will you explore and look at prevention of bowel cancer for the next generation, and if we capture some of the other generations at the marae, is that something that will be kind of addressed or looked into?
Most definitely. So obviously the things that we eat, what we eat, so it's maintaining a healthy diet. We're looking at marakai, just to try and enrich our culture, embrace our culture, and go back to the things that we used to do. Mana community, working together, community, you know, with community, for community. So healthy eating, getting back to that, and also exercise. Minimum of a half an hour a day. That's what we're promoting. Obviously, if we're working in the garden, we're getting more than half an hour. But it's just trying to encourage our whānau to keep active and eating well. Foods high in fibre.
Yeah.
High, fruit and veggies, a lot of those good foods which we already know about.
Yeah, Māori actually have a lower rate of bowel cancer than non-Māori. Their chance of getting bowel cancer is lower. The problem is they tend to present at a later stage, so their outcomes are worse.
My question is, how are you going to manage with all those colonoscopies that are going to be required?
Actually, looking at the volumes, we've done some production planning just to make sure that we don't overload the system. Once we come to the point of needing to do colonoscopy, we're based on the population and the number of positive fits that we can expect. Looking at approximately 4 a week. So we've built that capacity into our system to be able to deal with those as well.
Or additional?
But I think the other thing is that one of the things that Tairāwhiti does is we get on with it.
Yeah.
And so, you know, I know the word goes out, we're running behind on scopes, and I've got surgeons that say, yeah, I'll do next list. We've got Sue who will be absolutely managing those lists and making sure that there's another one in the list to make sure that we don't go outside those timelines. And that's just what we do, because we don't have the ability to outsource it and or share them. So we tend to just get on with it.
I guess that was my question, was how well resourced are we? But so you were talking about it at an age space, but are there ever any children that have this kind of condition, or is it simply that it is as you get older? Because it makes aging seem like not a cool thing. You know, so, you know, in respect to positively aging and keeping well, but also are people who have it in their family, is it a, you know, genetically inclination, are they at the top of the list type thing, or is it something that you turn at this age and then here we are?
Yeah, so bowel cancer in young people is usually due to a strong family history. Those patients often have a gene that they carry that gives them bowel cancer at a young age, and that they can pass on to their children. And that's why family history and identification of a family history and knowing what your granddad died of is so important, because and part of the pre-assessment process where we check people in for colonoscopy, we take a thorough family history and identify those patients who meet the criteria for a screening colonoscopy from from a very young age. So where patients getting colonoscopies when they're 35 because they have a strong family history.
Yeah, and you mentioned that test in respect to Tairāwhiti. Is that stopped, or is that still something that happens?
No, that's how the test is issued by normal process. It's not the test that we will be doing the same test, but not through an envelope, not through the post.
So the important distinction is screening for bowel cancer, which is testing people without any symptoms, so a stool test, and investigating symptoms, so patients who have blood or change in bowel habit who go through their GP.
Cool. Thank you.
So, following on from the conversation around the age, I guess for somebody who seems to be outside the boundaries of everything, age-wise, you know, breast cancer, I got it too young, you know, all of that sort of thing. Is there capacity within this program for the volunteers to rock up and say, you know, can I get involved?
Not for screening, because the screening is for a particular age range. However, if you meet the criteria, if you meet the symptomatic criteria because of your family history, etc., you can go through colonoscopy.
My point being that if I had waited for that, I would have probably not been here now. How do we address that?
Yeah, so there will be some patients who don't have any symptoms and have bowel cancer and aren't picked up by the screening program as well. Okay. And that's just part of the screening program is not 100% perfect, but the people test.
Okay, yeah.
But it's a matter of weighing up the cost of endoscopy, which is a limited service, and the benefits.
I guess it's just, my question is there a potential for those who had granddad and mum and they're 25 and they're going.
Yes, absolutely.
I know about the familial study, okay, so I guess it's whether or not the testing kits as compared to the full-size colonoscopy are available.
So the testing kits aren't available for diagnostics for that. That would be a referral for colonoscopy.
Well, you could get fit tested by your GP. I mean, your GP could get you fit tested outside of the program.
No.
Surely, this fit test must be available. No, only
it is available, but we're being told to decline fit tests outside of the program. The reason is that fit tests that are in the program have been tuned to pick up a certain number of bowel cancers, and the ones that you can buy at the chemist have a much lower threshold, so they're not as sensitive or specific. And the ministry just doesn't want people willy-nilly doing it because it's going to potentially overload the colonoscopy resources.
I just had one thing I just want to thank you for the corridor to come on, because we're obviously focusing on equity in health, particularly for our vulnerable communities, Māori Pacifica. So does this have an on-flow effect of learning about bicultural practice and all those factors? Because it seems exciting to know we're finally getting into those spaces, so you're learning more from our communities about other things, because I'll bring that up and other stuff might come up about how they're feeling, etc. Is that gleaned from this?
The other thing too we need to take on board is our mokopuna are getting educated in a different way that I was educated. And so we can use that mokopuna to get the message across to Nanny, Uncle, and those sorts of people.
Cool. Anyone on Zoom? Josh, Kim?
Yeah, I do. Actually, te tuatahi ngā mihi nunui ki a koe tā tātou kaikarakia mō tēnei ata, ki te timata pai tā tātou hui, nera te mihi nunui ki a koe te whanunga. Ai tautokohia ngā mihi kua mihia ki tākuta ngata ki era atu whānau pani I raro I tēnei wā pauri, nei rata mihi nunui ki a rātou. Mā te atua e manaki e a whina e tautoko atu ki a rātou. Good morning, whānau. I've really choice kōrero in regards to bowel cancer. I wanted to know, actually, I want to more kind of place something for discussion across around our board and with our CE when we get to the paper, and it's in line with what Dr. Heather had said in regards to how we're going to carry this caseload of bowel cancers, because I appreciate the fact that our planned care production has we're over target and we're slowly chipping away at that, but we're non-compliant in a lot of areas. One of them's not inside the bowel cancer area. I don't know if that's because it's not reported on yet, but I do wonder how we're going to deliver on this as a DHB, knowing that we're non-compliant in so many other places. So I'm really keen to hear our kōrero when we get to page 21, 22 of our report. Kia ora whānau.
Okay, well, thank you very much for the awesome presentation and a wonderful rollout of the bowel screening program. I wondered what it would look like in time, and I'm pleased at how it's turning out, and I look forward to seeing. Yep. Thank you so much.
I thought of my head in my leg note.
Okay. Okay. Rachel, apologies. We've got them listed. Robin and Gavin.
Now we'll be joining after morning tea.
Okay.
He's going to have to test.
Okay, anyone got any updates to their schedule of interest or any interest that conflicts with anything in the agenda?
Oh, I thought I mentioned
Oh, was it a week?
Still
So
can't
what was
speak
it?
Yeah, mass.
Yeah, sorry, can't hear you.
I had
Yeah.
surgery.
Oh, you did? Nice.
On my vocal cords and my ankle.
Nice. That was quick.
Beautiful.
Okay. Any previous minute, anything, any comments on the previous minutes? We take them as true and correct then, or do you want to have a few minutes to catch up? Okay, who wants to confirm them and who wants to second them?
We just usually do that.
Oh, don't do that?
No, yeah.
Okay, matters arising. Nicola. COVID testing at the port, we've done that, haven't we? Model care, it's in the agenda, finance report and agenda. Proposed date for changes to the committees in the agenda. Board photo won't be happening today.
Second question. So Nicola, it just says here that there is a regime in place. I think I saw a headline in the newspaper, something about testing at the port. Can you just give me very quick?
We've had our direction 2 Fridays ago to prepare within 3 days of the start of work at the port to be tested. That was ratcheted back a little bit because the focus was actually on Tairāwhiti and Auckland ports. But we are now requiring the port staff to be tested, and so we've got all of the names, and they are gradually being put through a testing regime. We did the first lot of around 30 at the port, but now the rest of them are coming, being sent invitations to come to the big zone to be tested. So we understand that there will be mandatory ongoing testing.
And what's the time frame for getting the first group tested? So we've done 30 so far. And
No, we've done more than 30. Within the 3 days, we get 30 done.
Right.
And then the ministry changed the rules and said that was to focus on Tairāwhiti and Auckland. And we have been moving through all of the port staff. I'll come back with an actual date when the port staff will be completed. I was looking at this last night. We have to make sure that whom we've seen have been recognised as being seen by the port as well. So I can provide the information about it.
Any other questions? Okay, we will move on then to the dashboard. Do you want to say anything about it?
Yeah, I was going to talk a little bit more about newborn enrolment. There's quite a discussion at Tairāwhiti about that, and we've got a meeting this afternoon with our partners around how we might improve that. A note that that is at 6 weeks, but by 3 months we're at over 80% enrolled at that point. So it just seems to be a problem around that time that we need to work with our primary care practices around flipping them over to be enrolled at that point. So I'd highlight that and just highlight again that we still don't have the reporting in here right, and probably we should just drop it out for computed tomography, CT and MRI in there. So those rates look low there, but actually are higher when we would check those through exactly with those people. Yeah, so that's pretty much the highlights that I would say out of here this month.
Yeah, well, the CT and the MRI scanning figures are extraordinarily alarming. We have raised this before, so let's get this right, because as a board, we want to see what is an accurate representation of our diagnostic waiting time. That's a really important step.
Yeah, it's just I can just assure you that it's just the reporting. It isn't the actual the reality of them. Is that they're on target.
So, other than us, who else sees this dashboard?
Nobody else, just you see that one. The public see this dashboard because it's a publicly released item. But yeah, is that what you mean?
Yeah, does the ministry see this dashboard?
Only because we send this agenda to the ministry every month, so.
Right, there's not some wonk in Wellington watching this dashboard.
No.
Meticulously.
No.
Sorry, Heather, one of the things I was looking at was things like the first specialist assessment and missed appointments, and I was looking for percentages in terms of helping to reduce inequity. So if you look at the hospital events on page 15, and you look at the first specialist assessment for Māori, that number is actually less than 50%. And, you know, it sort of opened my eyes as to how we need to look at the numbers. Should we be asking for, do we used to have these as percentages, Jim?
The difficulty around a measure like that is that it is difficult to assess what the percentage would be. Remembering that, and I guess bowel cancer is a really good example of that we've just talked about, is that the predominance of a condition like bowel cancer is in older age groups, and as we know, the proportion of people in the older age groups who are Māori versus non-Māori is quite different than the overall population. So it's difficult to say what you would expect the percentage of Māori to be in a particular indice such as first specialist assessments, because of the pattern of presentation and things like that. So there's some fundamental things below that. So you could present a picture and a figure and say it's X% of the total population. You're seeing it there just under 50%. But and then you could compare that to what is the proportion of Māori within the population of the people who have been referred through, and see whether that whether that's similar or not. But then what would that mean? With some conditions you would expect Māori to be more referred through for first specialist assessments, and possibly for some conditions less. So it's difficult to come up with what a percentage should be, and therefore then apply a target around that.
Did there not used to be a readmission rate under the hospital events? Or is that something else?
Somewhere it's on the first page, I think. Acute readmission. Yeah, it is on the first page under acute readmission rate.
Okay.
There is a.
Oh, I see. Sorry. And then later on, we'll be seeing a screening section with the bowel screening. Probably good to have the cervical screening and breast screening section in there as well. Once we head into the screening bits.
Yeah.
Okay. Anything else on the dashboard?
Heather, it's Kim here.
Sorry.
So just picking up on the point Josh made earlier. So for the colonoscopy diagnostic waiting times, is the bowel screening program, are we going to have capacity to deal with what comes out of the bowel screening program?
Yeah, so you might have just missed the stat there, which was the modelling shows that we could get another 4 people a week requiring a colonoscopy. So that's roughly one extra list of just under one list of colonoscopies a week additional. So that's what they're planning on, and there's additional resource from the Ministry of Health to enable us to increase the capacity of our systems to cope with that increase.
And will we have the specialist staff to actually do it?
So we are actually, what we've deliberately done over the last few years is to ensure that all of our general surgeons are able to do colonoscopies or do endoscopy. So not just colonoscopies, but gastroscopies as well. So we did have a difficult period of time a number of years ago where only 1 or 2 of our consultants were able to do that procedure, but now we've got the whole 4 of them. And they're also this year getting some additional registrar support as well in the team, utilising the bowel screening money, so that they can actually have the capacity to be able to do that extra list a week. That will be likely to be necessary.
Excellent, thank you.
The other thing is that with the screening program, ultimately, you will find people earlier, and so you'll just cycle people back earlier into their disease, so the colonoscopies will just occur at an earlier time in disease, and whether you get much better outcomes for people as well.
I guess following on from the additional colonoscopies, there will be no doubt additional surgeries arising from that. How does that all flow through?
Well, the thing about that is undoubtedly there'll be extra surgeries, but they will more likely be polypectomies rather than bowel resections. So that's, that is another point of it really, is that you intervene earlier for the health system. The complexity of the surgery is lessened. There won't be the need for stomas and all of the care that's required, reversals, a period of time later, those sorts of things. So that's the practicality of getting in and finding people's bowel cancers earlier, is you can intervene earlier. Sometimes you'll be able to actually remove a polyp via colonoscopy anyway. And obviously, if you've got it early, then it doesn't develop further, that you then need more extensive surgery later. So that's another practical reality of the bowel screening program. Good for the patients and good for the health system.
Okay, thank you. Chair's report. It's you, Jim.
Chair's
Oh,
report.
sorry. Sorry.
CE's report.
Oh, CE's report.
CE's report. I think we have
CE's
Chair's report though.
It's got Chair's report, but we have got CE report next. Chair's report.
Verbal.
I'm happy to give the usual verbal report. And firstly, ngā mihi kia tātou, ngā mihi hoki kia Uncle Herawini, me ngā tākuta teina e rua kua hinga. Apologies for not being there in person today. I got a bit unwell over the weekend, and talking with Jim, we decided that that I shouldn't be bringing any bugs into the hospital setting. And ditto, Josh is in the same boat. So thank you for having us on Zoom. So just briefly, and the things that I was going to talk about are covered in much more detail in the Chief Executive's report. No surprise that the feature over the course of this month has been the resurgence of COVID-19 in Auckland. And then, although it's not here, the associated preparedness needs to occur across the whole country. So this has been a feature of the discussions amongst chairs and with the Director General and the Minister over the last few weeks. Just some of the highlights just to pick out. So for testing, just a reminder that testing is for those who are symptomatic and have been referred by their doctor. We have had a huge surge of testing, both nationally and also in Tairāwhiti. I think our highest day was around 240 tests. Just in the last week or so, the Ministry of Health has started publishing testing data by DHB over the previous 2 weeks, which is actually what really matters. So for a long time, we've been testing the highest rate of the population overall since the start of testing, but now it's really much sharper set of figures when you're considering testing over the previous 2 weeks. So when they last published, the figures are about a week old now. We are now behind the surge regions. So the surge regions where there's been a huge amount of testing is, of course, Auckland, Waikato, down in the lakes in Rotorua, and also in Northland has been a very high rate of testing. So, so where the surge has happened, that's now the highest testing of the population. Then Tairāwhiti is next. So I did just want to underscore that to hopefully give some level of confidence in our community that we are maintaining a very high testing rate, and that's an important part of our defence in making sure that if COVID enters our community, we do catch it early. I think going forward, the Minister and the Director General have been quite clear that actually we need to make sure that the testing effort is directed at where the highest risk across the country is. Alongside that, we are in the process of standing up a second testing site in the city so that we can ultimately build up what's currently the pink zone in the hospital to be a more permanent arrangement, not just for COVID, but for any kind of infectious disease that might require an isolated area in which we can test potential patients. Again, there's a lot of the work has really followed the template of last time. So things like preparing for red and green zones in the hospital. We haven't had to move to that. And the good thing this time round is that we haven't had to stand down any planned care services. So health services have continued. And I think that's a really important thing that we will be aiming for going forward, is that we get the right size response in the region. So when we had to lock down in March, the whole country had exactly the same response. And while we were, did very well here in terms of COVID, we had to stand down a whole lot of health services that ideally next time round, what we'll actually want to do is to make sure we right size and negotiate with the ministry for ongoing planned care. And not just with the ministry, but also with clinicians and colleges. I think the really different things this time round for us, one thing that we've talked about, which is a much closer attention to our border facility, so down at the port, and also the change with confirmed cases now going into a managed isolation facility rather than isolating at home. So we will have a managed isolation facility locally if it's required. So those were the main things I just wanted to highlight. But again, there is much more detail in the Chief Executive's report. And then just one more thing, just to for the board's awareness. So we've got our Manuataki meeting of the 5 regional DHBs next Friday. And then after that, the October meeting, Tairāwhiti takes over chairing the 5 regional DHBs. We'll be doing that for 6 months. So that will be a joint chair between myself and Nārai Hania, who is chair of our Māori advisory group, and Jim will be our lead CE. And we'll be doing that out until the end of the first quarter next year, and then it will rotate through to one of the other DHBs. So that'll be a wee bit of an extra thing on our plates, and having that stint of chairing the 5 DHBs. So Kwena Taku, happy to take any questions.
With the isolated facilities, is that something that's going to have to come out of our budget? Or is that something the ministry is going to fund on top?
No, we'll be funded for an isolation. If we need an isolation facility here for somebody that's in managed isolation, we'll be funded for it.
Okay, thank you, Kim. Josh, you happy to wait until 10:30 till Nga turns up for the T1 report?
Yeah, I think that'll be the best best idea. He did send through some notes, but he's coming back after morning tea. I suggest we just put that item of the agenda to after morning tea.
Sorry, can I just add, and it was very remiss of me not to do so. Heather, thank you for taking the chair today. It's just too difficult to chair a meeting when you're on Zoom and everyone else is dots in the distance. So thank you very much for taking over the chair for today.
Even though I'm mucking it up at times.
No, maybe.
No judgment, it's all love.
Can I just ask a question? So that's, I guess, a bit left field. I just noticed that it's wearing a mask. Would you recommend for role modelling in respect to our role in community space to wear one like you are?
Okay, I was going to bring up the topic. Is it my report?
Oh, sorry.
Yeah, sure. Unless there's other questions in relationship to the chair's report. So I'm wearing a mask at present because I've been out of district. I've been in Auckland, and I developed, and I've also been away on holiday, and I developed respiratory symptoms while away on holiday.
Been tested?
And I came back and was tested, and the result of that was negative. However, I've still got respiratory symptoms. You might have heard I've got a post-viral cough that is persistent, and so our policy is that people returning to work after they've had a respiratory need to either wait until they have all their respiratory symptoms have gone, or it may be that, depending on the person, that wearing a mask may be another solution to that. my history is if I have a viral infection like that, I do get a persistent mild cough for long periods of time. So it's not really practical for me to stay away from the worksite for weeks while my cough goes. So I'm wearing a mask in the interim. So that's why. Yeah.
So we don't have to, in respect to.
No, but I think that if you know, obviously, if anybody who's got any, respiratory symptoms, sneezing, cough, fever, loss of smoke, taste or smell, all those things, they should absolutely go and get tested. And also, they shouldn't be out and about with those sorts of symptoms, and not passing them on. But if you do have to go out, or if you've got like a situation like me with sort of persistent symptoms, but persistent symptoms, then it is advisable to wear a mask in those situations. And of course, from Monday, everybody's going to be wearing masks on public transport and those sorts of things as well, or a face covering to be more.
That's Auckland specific, though, isn't it?
No, everywhere in the country from Monday. Yeah.
Another reason not to use public transport, I say.
On all of our buses. But your electric bike will be fine.
That's right.
What you came here this morning on will be fine.
And will the frontline health workers be required to wear a mask as well?
No. So at the moment, we are the setting that we have within the hospital here is that anybody who is a frontline health worker who in the course of their work is unable to maintain at least a metre away from people during the course of their work needs to be wearing a mask. And also conversely to that, where people are coming into the hospital, we are asking them to wear masks when they come into the hospital. So that is people coming for appointments or people coming to visit people within the hospital, and so that's what we ask them to do. So people who aren't in frontline positions, who aren't going to be within a short, within 1 metre of other people, don't have to wear masks. Hence the fact that we're all sitting in this room today without needing to wear masks, as long as we're staying roughly a metre apart, which roughly is about right here. And of course, there won't be anybody in the room with respiratory conditions anyway, so that's good. So that's the settings that we've got at the moment, and we will clearly take that down a notch from Monday if we do go into. Actually, no, we'll still be level 2 on Monday anyway, so another week of level 2, so we'll still carry on those for another week. Coming to my report altogether, financials, slight deficit and slightly over budget for the month, and probably not a lot we can infer from that. A lot of those figures are accrued to budget. Early days, we've got our 150,000 non-specific accruals in you as well. So it's difficult to say a lot about what that means at this point. We've got some additional revenue in there for COVID-19 costs and definitely some additional expenditure at present as well. So that's all within there. The utilisation of health services has picked up, as you can see in the graphs there, and I can tell you that at this precise moment, the hospital is pretty much full again as people have come in. Some of that is people with conditions that have been followed up that maybe had some problems during lockdown period and weren't accessing the health system for a variety of reasons, and now are, and also respiratory infections in the community have sparked back up again. So good to remind people about cough and sneeze etiquette and utilisation of masks where that is appropriate. So you can see the figures have popped up there in all of those graphs. I probably really want to just concentrate a lot around resurgence. So as I've talked a little bit already around that, we are, just before I get to that, I'll just talk about planned care production. So we've had a really large hot start to the year, 123% of our planned care production in the month, and that's partly the reason why the hospital is quite full at present, because we are not only working to look after the people acutely, but we're also trying to get as much of the backlog through with our planned care production. And there's a report that you've got in there coming up, which we can talk more about when we get to that point. So COVID resurgence planning on page 24. Just wanted to highlight a few things in there. You can read there already that we've got our emergency coordination centre set up again, and that occurred when we got the message from the Prime Minister around the resurgence and setting up of the two emergency operations centres, one for our hospital and DHB services, and the other one for public health and primary services. And they have been hard at work, tailing off a little bit now as a lot of the systems and processes put in place, and that the resurgence appears to have been contained in the country, so less of a pressure on that, but definitely from a public health point of view around testing and testing people, not so much tracing at this point, but a requirement to set up the testing and tracing capacity. And so Nicola and her team have responded to a request or requirement from the Ministry of Health that we substantially increase our capacity and have that planned out, ready to go should we have a resurgence in this community here. And the modelling was around 4 to 5 people per day testing positive for COVID-19. So as you can imagine, that is quite considerably different than anything we've ever experienced over the period of time. You know, if you remember, we had 3 people test positive over 2 months. So that has meant that we have looked around the numbers of people that we would need to be involved in that. We are primarily utilising the public health team within Nicola's team and the public health nurses, but clearly we need to add in more people to that. So we've got those people as the experts, and then we've got other people who aren't necessarily in public health roles but can come in and support behind those people, other health professionals and teams. The amount of testing in that scenario would be quite large, so we've got to look at the numbers of people we need to be able to provide that, the sites, all of that. So there's been a large section of work on that Nicola and the team have been leading to make sure that we are ready there. We've also have been asked to have capacity here to be able to support our colleagues in Auckland should there be a need for that, but there hasn't been a need for that, and obviously the pressure is starting to come off the Auckland teams as well on that. There's a couple of, in terms of hospital preparedness there, we've obviously got our red and green zone planning there, but haven't had to put that in place. We are currently checking everybody at the entrances and making sure that they don't have respiratory symptoms and providing them masks to enter the hospital. We have been looking at our personal protective equipment requirements, PPE requirements for our staff, modelling those again, seeing if we've got enough capacity, and particularly looking at for fit testing of N95 masks. What we have now got capacity to do is we've got hoods that you can put over people. You spray a chemical in there, and they've got the mask on the hood over them. They spray a chemical in there. If they can taste it, then the mask isn't fitting appropriately. And we're finding, as in other DHBs around the country, 60 to 70% of people who are being tested on our most commonest mask, the mask is not satisfactory, and so then we go on and test them with a different type of mask, and that improves the situation, but we haven't got 100% coverage, and this is a common feature across the country, and so a lot of that seems to be size related, and so there's work going on to access smaller size masks for people to make sure that everybody's got, if needed, and a N95 mask that works. Obviously, there's no point in having them if they don't work properly. So that's one. And then the other one that is in there, 2 other things that I specifically mentioned in there is around the Ministry of Health asked DHBs to survey their oxygen and environmental requirements. And we did that probably at least a good month ago now, maybe 6 weeks ago. Every DHB did, and 11 DHBs came back as needing some further work on oxygen and environmental requirements. We're one of those. And to cut a story short, we have put in a program of suggestions about how we can improve. Well, they came back to us and said, here's how we think you could improve your oxygen. we've got enough oxygen on site, but it's the amount of flow. If we modelling having between 5 or 6 people, with those numbers we were talking about, that many people being found to be positive every day, then that would flow on to around between 5 and 6 people in intensive care as a result of that. And so that's a lot of oxygen that you would need to be able to ventilate those people. And I'll talk about equipment in a moment. So ventilate those people, and then approximately 5 to 1 people in the ward as well. So that's another 20 to 25 people in hospital with COVID-19 as well. And they would be, many of those people would be requiring oxygen utilisation as well. So do we have enough flow literally from the tank into the hospital to get to all those people? Is it going to the right places? Is there enough rooms in the hospital that you could actually manage the care of those people? So, in a short story, we put in a proposal to lift our capacity across all of those areas, and that's around about $900,000. So we will see how much of that, and not all of that would be absolutely required, but we'll see how much of that we get. And as I've said in there, because as in that next piece there, we are getting some additional ventilators out of the new national supplies. The government has bought a large amount of ventilators for the country. If you remember, when we first went into this, we were comparing our ability to ventilate people compared to other countries. We were on the lower side of that, so that's been fixed. Our capacity, as I said, there is going up by 250% from 2 to 5 people at any one period of time that we could ventilate. And that's that list of equipment there, that we have got an extra 3 ventilators that we will be getting probably in October now, and all of the other pieces of equipment that go with that to improve our capacity to be able to manage people in hospital or who are needing ventilation. And the other thing that I would mention there is just the Rotorua Order resurgence plan. So Rotorua Order is the regional recovery plan for the COVID experience, and there's been a piece of rapid work done just to specifically address resurgence, and that's been finalised this week in terms of community-based actions across that. Our annual plan is in Wellington and should be signed very soon. We're in the first tranche of DHBs to have the annual plans signed this year. Don't know how many in that plan, roughly half of them, I think. 11, are in that group to be signed imminently by the minister. And just at the bottom there on page 27, there's a few things there that I just wanted to highlight. So any of you walking in this morning will have seen the MAB is well and truly down at the moment. They're digging out the old foundation so that they can backfill it, and it will completed, still expected to be off site by sometime in September, first week in September, done. The Mental Health and Addictions Facility, we have received confirmation from the Minister that the funding for that is approved at $18.8 million. And that enables us to then move on to the next stage of the design phase. And we just have to run a quick tender around who's going to help us with doing that design. And not sure if there's going to be some official announcement of that yet around funding. Child and Youth Hub, I don't have an update about what's happening with that, but radiology reconfiguration, we have now put that into the capital program. If you approve that later on today, that will be going ahead relatively quickly now, we hope. Just a few big things. The Director of Nursing role review is almost, well, the actual review is complete. The job description is almost complete, ready to be advertised. The group manager information has been appointed. That's Max Ponomara, who I'm sure you have met before and will know. The clinical portal for us is going live on February 22, 2021, and there's a paper later on the agenda. All our patients, all our patients in the right place is the piece of consultation that we've done around the reconfiguration of the hospital that actually was talked about late last year, but didn't progress because of the COVID-19 experience. And that's also added to our knowledge that our configuration wasn't working as well. So could. So staff have come up jointly with an improved way of doing that, and we're taking that back out to staff now with what they decided to do and implementing that. Sustainability funding, back in budget 2019, the government put up $63 million, I think it was over 3 years, to fund DHBs and the health system around ways in which we're improving sustainability. That's both clinically and financially sustainable. And some of that money has been utilised for some of the training programs and information intelligence work that the ministry is doing. But now that money is also being made available to DHBs, and we have been offered the opportunity as one of the early pilot DHBs of putting forward some proposals that would obviously improve sustainability. We've got about 4 or 5 that we are going to be submitting very soon. That's been delayed a little bit because of our efforts around resurgence. But they are projects, and I can get that to the next board meeting, they are projects which are not only for the DHB sustainability, but also for our primary care and iwi provider partners as well, in terms of things that they can be doing to improve their sustainability around clinically sustainable and financially sustainable. Planned care funding, we have, and I mentioned planned care before, but we have got a figure of just over about $950,000 out of the money that is available this year from government on top of our normal planned care funding to be able to $283 million over 3 years, of which $50 million is for capital works, and our share of the base funding is $950,000 that we'll be utilising to improve our speed of planned care. That'll come up in the paper that's coming there as well. And there's also the $50 million of capital, which we have got a plan about how we would put in a bid for some of that around the procedure room, which would take pressure off our theatres and improve the flow and speed up our capacity to be able to get people through planned care. And Matai Research Institute, Lisa, should have been on the agenda there, saying that the lease has been approved. That's me.
Anyone got any questions for Jim?
A couple. The air transport costs, page 17.
Yep.
And the corridor, page 24. I can't reconcile the two. Can you just explain it to us, please? The corridor on page 17 says air transport expenditure was $109,000 over for the month, and it's $174,000, or 91.6% higher this year than last year. So can you just explain briefly? I thought we bought a contract which allowed so many flights, and that's our relatively budgeted air transport costs, or do we have a budget on top of that which we're just blowing out crazily? And then I look at the commentary on page 24, which says, where is it? Page 24. The percentage of patients transferred by our team was low at only 57.8% of all patients and only 38.8% of all missions due to pressurised aircraft in our schedule. So can you just explain what's going on here?
Yeah. So I've actually just restarted that, or that graph has just been restarted for this year. So if you actually got last year's graph, you would show that we've got a lot of more transfers in this month. So that would explain the difference in the amount of people coming through and the cost of that. The cost is, there is some base funding component of non-pressurised flights, but the pressurised part of it is a price volume contract, so there's no cap on that, and so it's clinically driven demand. During the month, as referred to on page 24, the pressurised aircraft that we utilised through EGIS was out for scheduled servicing. And so that meant, and for that period of time there, so right across the month, so that meant that we were, other alternatives were required to be used, but our contract means that the provider needs to reimburse us for the additional cost of that over that period of time. That's correct.
The additional cost we incurred over the period of time.
Yeah.
So we're covered for the EMS 18 flights per month at the discounted rate for each district. Up there, if we go into another price bracket. but like comments that, you know, Westpac Airbus was completed 14 flights. And
that would be very high.
The nurse only mission.
It's only got a nurse on it, not a doctor as well. Yeah. So that would be one that we normally would do ourselves.
The comment about obtaining the helicopter being not straightforward, was that just a one-off, or is there a problem there?
Yeah, that was just a one-off at that time. It was around a person who we wanted to get up to Auckland in a hurry for a thrombectomy, stroke thrombectomy. And the helicopter here was not available for some reason on that day. So we had to source another helicopter from elsewhere. So it took a little bit of extra time to actually do that. The person did get up there and had their thrombectomy.
The other question relates to page 21. And the fast cancer treatment pathway, it says on the 62-day pathway, there's 9 people on the pathway. And of those, 5 or 56% met the 62-day time frame. So 4 out of 9 didn't meet it all.
Yeah.
44%.
Yeah.
Stats sound bad when it's such small numbers, but I mean, it's only 9 people on the pathway. How are we not meeting 9 out of 9?
I think it might be quite useful at sometime in one of these meetings just to, I guess we can try and make it the sort of a nondescript person, but it would be quite useful to show some of those longer pathways for people. There's a really, I just know because I go through them every month, but it's just a really classic pathway for a person in those figures there, one of the people who didn't meet. And while it might sound a long period of time, 31 days to diagnosis and then 31 days to treatment, for some people, it is a very long journey around when they first get referred by their GP for what sometimes can be quite diffuse symptoms as to how you then track down what that is, the diagnostics that are required, the tests and things that we can do here, the ones that are needed to be referred out of district, the multidisciplinary team meetings that need to be held, often to have another decision made around what is the next, so you get down a point where the clinicians say, actually, now we need to do a whatever, test because we need to know more before we can definitively say what's happening with this person's cancer. So when you put string all those things together, that's what then takes us over that 62-day period for some people, and that's those numbers. Well, the 9 people on the pathway was quite a large number for us, and partly I believe that is in part around catching up around people who are coming out with diagnostics at the moment as well. So, yeah.
I wasn't questioning per se the 62-day figure, but the fact that of the 9 people, 3 didn't meet it, 1 for clinical reasons and 2 for capacity constraint. So 33% didn't meet it for what's clinical reasons and what is capacity constraint? Is that our capacity constraint? We couldn't provide the service to them, so 2 out of 9 people.
So clinical reasons will be that, one, obviously patient choice is somebody that says, actually, I'm going away, so I don't want I can't have my colonoscopy at the moment, can I have it when I come back, that sort of thing. The clinical reasons might be that we are, trying to get the person into, it is one of those where the journey is very long and it takes us a long time to actually diagnose what the person's cancer is. And that was the one I was referring to that started off with a person who had some difficulties with swallowing and then actually eventually found out that they had a sarcoma on their leg. So, quite an amazing journey to get to that point. The capacity constraints will be where for instance, where we need to send somebody out for a PET scan, a PET scan, and to get booked into that, you might take an extra week to be able to get them into a slot. So that adds another week, and that takes you over the end of the time period. Yeah. So that's it. Or it may be that they need radio, they need to go over to Hamilton to be scheduled in for their simulation, which is they need first, and then they actually get the radio. But by the time they get scheduled for the simulation and then get into the radio, it takes them over the time frame.
2 more questions. So are you happy with that status?
No, not for that month. I mean, generally we have been reaching targets on that, so I was not happy with that month, and so we spent a lot of time on what actually went wrong for those 3 people. Yeah, and but that is the amount of work that is going on by our team within the cancer services all the time to try and keep people forward. But where we can actually find things that we can speed up on, then absolutely and we need to work with our regional colleagues as well to be able to make sure that Tairāwhiti people get in. But some of the things around the which are talking about capacity constraints are often things where somebody needs to go back to a multidisciplinary team more than once, and because there's numbers of people coming into those multidisciplinary teams is when you can schedule our person in to get in there and have the conversation again from the multidisciplinary team to say, yeah, we know enough now, this is what we should be doing around treatment, or no, we need another whatever test before we can actually start treatment on this person.
Okay, my last question is on page 23, the severity assessment code events.
Yes.
Will we be getting a fuller report, or that come to Frank group about the SAC event where a person took their own life and another one took their life? So there's 2 suicides, isn't there?
Yes. Yeah.
So will we get a fuller report on that? And is that a risk for the hospital and for the board? Should we?
Obviously, somebody who leaves the hospital and then later commits suicide, complete suicide is absolutely something we want to report. So there is a review going on about what happened there, that person. Yeah, so yes, we can get a report. Well, I will be getting a report back, so you can get a report back about what happened and what we're doing about it. The other one was a person who transferred to who left our district and went to another district, was transferred to mental health services in another district and then committed suicide there. So we will get a report back from that other DHB about what happened there. But it's more concern. I mean, that is concerning, but a really great concern is around the person leaving the unit. The person was not a person under the Act.
Thanks, Jim.
That's small.
Sorry, time frames on that?
I think that, there should be for next month, there should be a report on that.
Yes.
Can I just add, just follow on from Jim's comment around some of those, the cancer journey, and somebody who's been through it here in Gisborne, we are so on point in this region compared to others. It's quite extraordinary sharing my story with people from out of district. And for all the fact that, yes, we follow those measurements through, and so you are, I believe, personal opinion, very lucky if you're diagnosed with any cancer here in Tairāwhiti.
Thank you for saying that, Sandra, because I know that the team, we meet every month to go through just to see. So that's just a month review, but I know that every day, once they get people through with high suspicion of cancer, they've got the stopwatch, tick, 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 tick. What are we doing? How are we getting them through? What can we make sure that people get through? But unfortunately, sometimes it doesn't.
I guess my point being that even if there is a block, if there is a capacity issue or whatever, at no point do you feel that you are out in the cold, because that will be thoroughly communicated with you. The relationship building within the team here is quite extraordinary.
It's nice to hear. Thank you. Come, Josh, anything? Okay. It's 20 to 11. We finished that before we go on to your report. We have a cup of tea because some people look like they need a coffee. Or do you want to go first?
No,
Why do you want to take off?
No, I'll do that.
Well, you can have a cup of tea and come back to us.
So what about the hearing? Because of, yeah.
Right.
Yeah.
specifically to see if people are following it and picking things up. Jim,
And he always
and
finds.
I wondered whether it was maybe budgetary constraints or that your F7 spell check is broken. But on page 19, in one paragraph, it's 4 lines long, there are 5 spelling mistakes.
Yeah.
And I did wonder if you were trying to teach us, Latvian or something with indents and condions and conchons.
Yeah, I think that
increased acticity.
We're about on page 19.
Yeah, I did the graph.
That's so unlike you, Jim.
That's brilliant. I just sort of
The
increased acticity by people.
I think what we need to do, Rachel, is that for some reason, by history, in this thing, it doesn't spell check. The spell check drops out on pages. Yeah. So that is giving you an accurate of my accuracy of typing. Yeah.
This is really
just spell check. This is really me. That is really me. Yeah. When I don't have spell check, that's exactly what it looks like.
That's brilliant.
Which is twice as good as what you get from me.
I couldn't even go, Jim.
Yeah, thank you very much.
Right,
I did actually
serious.
when we were talking before, I actually did spoken
And hope no one
another one
picked
as well.
Okay, so we'll hand over to you, Craig.
Yeah, having taken the paper as read, coming from Jim's comments, it's not from the new financial years, typically. A lot of accruals to budget. We'll probably make comment on page 33 where we've got the board reconciliation of our financial year end 30 June 2020. From various iterations from row 0, the 30th where we finished year end. First sequence reconciliation of 13.1 and the second sequence down to the ministry on 10 August at 12.9 million deficit for the financial year. What is noted that we had just under $1.5 million worth of deficit, if you like, costs over income for better COVID related. So if we want to get 1.5 million out, we're doing everyone against budget of 12 million deficit for the financial year.
Okay, Tim's got a question there.
Craig, the 12.9 in deficit, is that inclusive of the provision we made for Holidays Act and for our COVID overspend that we didn't get reimbursed for?
That's right.
So that means then that if those extenuating circumstances weren't there, we would have come in about $1.5 million under budget.
Yeah, so we've got 997,000 that's related to the Holidays Act and 1.481 that's related to COVID.
Both not under budget.
So, yeah.
Okay. So well, can I just say well done, everyone, because that's really good. You know, those two things that have been, you know, if you factor those extenuating circumstances out, that's well within the agreed deficit.
Don't talk about that, Kim.
Anything else, Craig? Anyone got any further questions? Oh, that was short and sweet. Well done.
Well, he's saying adding a word. What is that? The account share of earnings. Is it share? Oh, I see.
Okay.
Yeah.
It's a SAR. It's a SAR.
I see. That's short version.
It's a SAR.
Board subcommittee reports, unfortunately, Frat didn't go ahead the other day because we had no quorum, but Tony and I were there.
2 does not make a party, apparently.
Although we did have a party.
Or act.
And so some of the stuff has been transferred over. And so Hauora Itirangi Committee, who's going to feedback on that, Josh?
I can speak to that. Actually, first I'll because I've noticed Nga isn't back yet. So like I'll speak to the Hauora Itirangi stuff and then I'll speak to the T1 stuff after that because he did send through an email. But I'll take the subcommittee kōrero in the papers as read, and I mean it's really quite straightforward. There's one error in regards to Whiti's name, but it doesn't really matter because it's only just spelled a little bit wrong in there. And the terms of reference, it's correct, and in the papers at the end, it's still incorrect, and that's the part where it needs to, where it needs to be correct. It's Kate Ppe. I wanted to mention it just in case someone around the table goes, that's not Whitty's last name, that kind of thing. But it's Kate Ppe. So I wanted to get in first and mention it before anybody else mentioned it. So, any questions or kōrero? Otherwise, that's pretty much iwi te rangi's kōrero on the paper there.
Okay, come.
Heather, can I just record for the board that I left the room during the Oranga Tamariki review discussion because of a conflict with that paper.
Thank you. Has anyone got any questions for Josh? No? Okay, T1.
Pai, the kōrero from Ngā in regards to T1 is number 1. T1 has requested a plan to address institutionalised racism and that it be action-oriented. Number 2, looking for more iwi involvement on appointment panels. Number 3, pleased with 33% of Māori employed, which is way higher in any DHB, but just a little way to go to reflect our population of 53% Māori. Jenny Roy attended workforce development. They've agreed to monthly reporting to T1, having a kōrero about recruitment policy, and Jenny also let T1 know about the institutional racism courses. And T1 has asked for that to come to T1 as well to see what it feels like and what it actually is. That was specifically requested by, well, the general sentiment was from the board, but the rationale was that one of the T1 board members had, inside of the organisation, they had someone come to them and go, hey, we're going to implement institutionalized racism training. And then their board had said, okay, can we have a look at that? And then when they looked at it, they were like, no, this isn't it doesn't really fit our org. So it's in that same light, T1 have asked for that to be presented. Eru Finlay attended and briefed about Kia Hauora, Hauora, training fund and te reo classes. Edu's actually just left us to become a lecturer at Massey. He just got his PhD recently, so he's been snapped up by Massey and he's left Hauora Tairāwhiti. And then the sixth and last thing was rangatahi to develop a wānanga, particularly to support young women in their development. Whiti was going to help develop a plan to be produced back to Te Waiora o Nukutai Memeha for consideration. So that's Ngā's kōrero.
Okay, anyone got any questions? I think Ngā's joining us somewhere, but I can't see his name up yet. Okay, thank you. We'll now go on to the board work plan, and that was prepared by Ian Diamond, so I'm not sure if anyone's going to speak to it. Nicola.
This is the first iteration of what we hope will finalise as an annual plan for the board in terms of a work plan that we've got. I just need to note that we would normally have this pass through an internal group prior to it coming, and I personally would have adjusted the Gantt chart that sits in, but it does come from activities that we've heard the board talk to, and then would expect that you would adjust and increase activities if that's what you would be interested in doing. So you'll note we have a number of workshops aligned to the annual plan. Again, equity strategy includes a workshop that would be able to delve more deeply into how the board participates in that. And then along the equity projects, there are a number of different things that we've included to support those projects as they move forward. And then there are some regular reporting activities that sit in variance reporting that we would suggest would come through to the board. These And the generalised activities on the top end would then guide how we would support Tairāwhiti and possibly T1 in terms of what they then would see as part of their work plan.
Okay, I just had a question about the Gantt timeline. With the equity strategy, is that if you go along to the Q2,
yeah,
there's a board sign off and a presentation. So when have we already had the information?
No, you've had the initial paper at the last board meeting where you gave us feedback about what you expected to see. Yep. We've taken that feedback back to the people who are responsible for bringing the information together. That will have quite a rigorous process before it comes to board to make sure that we've checked against what things we board expected. And while it's indicating a sign off there, it's not necessarily the end of that process.
Right. Okay, that's what I was asking, because I think
that's our high hope.
Right, because I think the information that we saw was about 1/3 of all the equity programs or approaches. Is that right?
The paper we presented last month, gave quite a high-level overview of the range of different areas that we could look into. We know from previous experience in other times of looking at identifying key things that might help us, that too many areas to focus on means a dispersed focus.
Right.
And so we'd be looking to have support from the board to land on a few key areas that you would consider the highest areas for us to keep focused on over the next 3 years.
And then my second question was, this might relate to a paper later on in the agenda, the board skills assessment. Where would we put that?
That should come into
this?
Yeah. So we based the work plan based on what the annual plan and areas we are already knowing will need to drop in, and this is expected to have you then say, where does this fit? Exactly as you've indicated.
Okay, because there were 3 areas, IT, HR and data or whatever that the team had put together from all our answers, and those were the 3 recommended areas that we might need.
So I don't have privy to that.
Okay.
And that would be helpful to have.
That's my question for Kim.
Okay.
Okay. Anyone got anything else? Kim?
Yeah, so just on the point that Hickey raises about the board skills assessment and development needs. Yes, I think you're absolutely right. We do need to build that formally into the board's work program. Also a question on the equity projects. So Nicola, when you go down into the equity projects, it says we're planning equity projects on addictions and healthy aging for implementation starting in the second quarter. Is that right?
For addictions, that's correct.
So that's a project, an equity focused project around addictions.
Yep, that's in our this year's annual plan.
Right. Okay. So what my question is so I see, I recognise we've got the equity strategy that's going to be our much longer term, these are the strategic priorities for equity, and we'll have a solid process with our partners around getting to that. But what process have we put around these very early ones that we're kicking off as quickly as possible?
Okay, so there's a paper in today's, around the equity projects, there's a paper in today's board papers that looks at the model of care for mental health. That's been underway now.
Yeah, no, that's not really what I mean. What I mean is, what's our process with our partners in equity to say, what's the most important things we should be doing right now?
So that's quite a challenging one to answer on behalf of the whole District Health Board. But what we can respond to you from the way in which planning and funding has established a range of different areas is that in each of the priority areas that we are working in, we've got a group that's working around us that does include, primarily it's the Te Rauwhiti Matua group, which are the 4 CEOs of the 4 Māori provider groups that we have, 2 of whom are linked directly into iwi. Actually, 3 of them are linked directly into iwi. We work with them on the different protocols or projects they would want to work with us on. Pretty much they're aligned to new investment funding lines. So at this point in time, we don't have a broader policy around how we would work with iwi Māori partners.
So that
what already exists.
Yeah. So that's so even with working with Te Rauwhiti Matua on specific projects, that's you know, you've got them together working together, for example, on something we might want to do in cardiology. And I think what we need to have is the step before that, where with our equity partners, we're saying, is cardiology more important than healthy aging? So that right at the very top end, there is that that shared prioritisation around what matters.
I would support that, and I think where we've built workshops that would enable us to do that, but these are primarily picking up on projects or plans that are already in play. And so we would, so for example, one of the ones in play is around the 3 projects that sit more broadly under mental health. And we have instigated a program to draw in iwi chairs, people who haven't been involved in the planning for DHB services previously. We've the first time engaged with that broader group to be participant in the thinking and activity before we actually kick it off. But it doesn't cover the overarching prioritisation process.
But Kim, I was just going to say, Kim, as this is the board's plan, you know, we have had a history of regular face-to-face discussions between the board of the DHB and the boards of the iwi. And while you know, while I think we as management within the DHB and management within the iwi health providers, etc., need to firm this up, maybe it is also a time for the boards to come together again to have those kind of corridor around those sorts of things, informed by the work that management provides. You know, saying this is what a pattern of health issues looks like across our rohe, and this is how it's affecting iwi, and therefore, yes, cardiology is more important than you know, healthy aging, or you know, those sorts of things might be useful as well.
Well, so my own view is that so if we can lock that into the big picture stuff, so if we've got our equity health needs assessment as our starting point, and then that is that's the evidential base on which we can have the discussion with our equity partners around what matters, so that is driving our equity strategy, that shared discussion.
Should we put a line in this then around that kind of engagement with the equity, with our partners, around about the sort of November point when we'll have the results of the equity, you know, the assessment
workshop?
Yeah. So, but separate to that, I think that workshop is a wider thing that you're planning on there, but maybe something specific between the board and the two principal iwi. Well, you know, however you like to describe it, but in around about November.
So if we bring in the first cut in October for the board to review, and then plan for a workshop in November.
Yes.
For partners to work together and then prioritise for the following year.
Yeah. I just wanted to make the distinction, sorry, Kim, that I think what you're talking about is our iwi partners there rather than partners.
No, I'm talking about that too.
So two workshops.
And I think that workshop should canvass things like what matters, but even things like the design of the equity monitor, like what's important to both iwi and to us in terms of what our equity dashboard might look like.
Yeah.
So that our effort is going into things that have got shared relevance.
Okay. Anyone else got any other comments? No, thank you. Welcome to Nga. I see you've joined.
And we've got one area in the board focused area.
Yep.
Are there any other areas that people on the board would like us to include? So we've got skills assessment that sits under the board focused areas. It sits, okay.
Bearing in mind that below, in terms, you've got addictions, Wahahua, anti-aging, cardiology, well child supplementary water and planned care and oncology as other focus areas that the board has got. So that's further down on the page.
Yeah, but
there may be
this
other
is
ones.
specifically for board.
Yes, yeah.
Are you asking what are some areas that as a board we want to focus on, or?
Yes,
well, yeah,
specifically for yourself.
Yeah.
Well, we've got the board skills assessment. I'm wondering what our treaty knowledge is like around the board, and whether we need a specific bit of mahi around that, because it's really going to help inform us as a board moving forward into our iwi partner kōrero coming up in October, November.
And maybe institutional racism as well, might be, because I think that's something that would be useful in planning, you know, just as you were describing, Kim, before, around not falling into the trap of thinking that we think this is the most important thing, therefore it is, rather than thinking actually what might other people think is the most important thing.
Can I also suggest, given the amount of capital works that's going on, I think it would be really good for the board to turn its attention to understanding our property master plan.
Yeah.
I think you also, Kim, had talked about, and I don't know whether it fits on here, but there was other things like CCDM, that maybe that was another topic. There was at least a couple of others that we had talked about whether there was something specific that might be topics that the board would be keen to have an update on. Holidays Act. And whether there was something around health and safety and employment.
So those kinds of things I think that you're talking about, Jim, health and safety aside, possibly more short, sharp, making sure that we understand this particular issue that we're facing, like, you know, the Holidays Act and pay remediation set of things, but not really an ongoing work program, just making sure that it's well understood at a governance level, and that we collectively feel assured that what the DHB is doing is addressing the issues we have.
Yeah, I was just mentioning them because I was really wanting to have some discipline for myself by actually getting them put on a page that says in September we're going to be talking about the Holidays Act, and then that's, rather than let's talk about it sometime, let's get it on the page.
Yeah, and I think that's a very good idea to do that as part of our ongoing board education.
Thank you, Nicola. Okay, next on the agenda is the disclosure of the chief executive expenses. Has anyone got anything they want to comment on or take it as read?
Cheapskate, no hospitality.
Yeah.
Where's the mini bar?
You've been staying. So I think you're very economical, Jim. Very proud of you. be interesting to compare it to other.
If you go to the NDF's website, you should be able to find every chief executive in the country.
Well, what's this living?
What about Canterbury's?
Yep.
Is there anything you could do, Jim, then to inspire those others then to,
They could come and live here.
Well, the Public Services Commission, and of course is, used to be called State Services Commission, is with the new act is just and we will, and those of us working within Crown entities are now become public servants. As a result of that, and the Public Services Commissioner has sent out the principles of being a public servant, in case we didn't realise. So I think these sorts of things around transparency and all those sorts of things, while they've always been in place as a requirement to do this since those events in the UK, it's just part of that whole thing around being open and accountable to the public for expenditure and the way in which we operate.
I do have a question. So just looking at some of the flights, costs, just as from a practicality perspective, flights to Hamilton, they are quite high, and I know that obviously the earlier you book, the cheaper they are. Is that just a standard flight? Obviously these Midlands, Hui and things like that are well and truly documented in advance, and are we booking those as early as we can to get the earliest flights? Because some of those are $600 to Hamilton, I would have thought.
Or are you going on
It's just tricky.
the little flight that has a standard fee?
Yeah.
That is the Sunny flight.
Oh, it's a Sunny, they have a
Sunny
set, they have a set rate. No discounts for early booking,
Okay, that's right.
and not pleasant to fly on a windy day.
No, I need to say.
The benefit for me of Sunny is that it's
There and back in a
direct, so
day.
you don't have the waste, the lost time travelling, but it is more expensive than it is on a small plane, and it is only back in the year again for another few. It's been back in the year again for a few months, so it dropped out for a while. Not literally dropped out, but
And it could have.
You're low when you can count the sheep.
Okay. Thank you for that. Proposed date and time change for the Finance, Risk and Audit Committee, not that there's many of us here. I don't have a problem.
I'll forward that or whatever.
The two that are away, it's a done deal, sorry.
So here we're just noting too that the date
Has
will not
changed.
change. It's just the time that the FRAC meeting will be held will move to 2 o'clock.
so 1 hour later.
So all 3 meetings will be held on the same day.
I thought it was 3 o'clock start. 1 hour less painting.
You see how they've avoided providing us lunch again?
Yes,
Still good.
isn't it?
But it's about saving money.
It's about expenses and being public.
Okay, so we approve that. Planned care improvement program reports.
I can talk to that.
Yeah.
This is, last month you got a sort of a start-up point around what's happening around planned care improvements. And so this is a follow-on to that. Talked a little bit about, as I did talk about in my report, about the funding that's been made available to us. I was a bit low, it's actually $977,000, not 950. And also there is, and I didn't forgot to mention around those service improvements funding that we can apply for separately, which is $7.75 million across the DHBs. We will put in some applications for this in our capital bid, which we haven't finalised yet, but we will put in a bid for that, as I said before, around the procedures room. And then just some early graphs there around what's been happening since we've been going into lockdown and then now coming out the other side of lockdown, and the fact that we are making some progress. So we are responding to the Director General's challenge to remove the backlog caused by lockdown by the end of the calendar year. And I'll make sure next month we'll give you an idea about how we're going around that. But you can see that even before we went in, owing to the large period of strikes and other action in last year, meant that we had people waiting longer than the 4-month recommended time or maximum time, and so we are fighting back against that gradually. More progress around surgery, but we're also having the issue there, and I think I've highlighted it, that we have got a larger number than usual of people being referred in at present, which we also believe is those people that may not have been to their general practitioner and for their problem, and now they're coming through and being referred in. So we've got to cope with that as well. Capacity is an issue for us in a number of specialties, but that's the point around the nearly $1 million that we'll be getting this financial year. It'll be the same next year and the year after that we're getting to be able to help us to improve capacity. And one example of that is adding in a non-training surgical registrar to be able to enable our full general surgeon specialists to be able to have more throughput over the period of time.
Jim, do you foresee any industrial action in the next 12 months impacting upon our catch-up?
Possible. We've got the agreement that DHBs have with nurses through the nurses organisation has expired, and there are negotiations that are occurring at present around that. So if that deteriorated, then that would have a major impact. If there was industrial action from nurses, that would have a major impact on planned care. That would be the most significant. There's a roll-on then of other agreements so the nurses are sort of seen as the sort of start of a bargaining round. So that's one. If we can get that resolved relatively quickly, then that would mean the chances of significant industrial action would be vastly reduced. The issue around nurses also is around, and that might be another one on the list of things that the board might want to update about, is around pay equity. And there's a pay equity claim for nurses. There's one for allied health workers, one for clerical workers, and one for midwives that are all currently under negotiation. The clerical workers one is the most advanced. They're actually negotiating as we speak on a settlement around that pay equity claim. They've done the work, they've shown the degree of sex-based undervaluation of work and are currently negotiating to a settlement around that for clerical admin workers in DHB. So so the one for nurses and the one for midwives is just a little bit behind that. So that will have an impact on those negotiations as well.
Okay. Any other comments, questions? No. Okay, moving on to the decision items, the capital budget. Craig, do you want to talk to that?
Yeah. So this is the information and decision around our 2021 capital program. Looking for spend of $6.238 million for this financial year, which is $993,000 above our free cash from depreciation. We will be rolling forward $2 million from the 2020 capital program, which hasn't been spent by and large to COVID-19. You can see at the bottom of page 48, sort of key projects contributing to that. Top of the pops is our Midland clinical workstation, clinical portal, which is $800,000 budget for this financial year, which is unfunded. So detail is from page 50, 51, and 52. Program. We did have a expedited sort of clinical review, evaluation. So we had two sessions with clinical staff to work through the list, which was, I think, started at about 2 million over budget of 2.4, so coming down to 993. Typically, in any year, we'll generally roll forward about $1 million worth of approved capital spend just from looking through the items.
So I think that means that while it is currently on paper here at being nearly $1 million over budget, so to speak, we're reasonably confident that we will be able to manage it within the total CapEx allocation in 2021, because we don't think we will actually be able to get through $6,258,000 in the next 11, no, nearly 10 months.
So my question is, and I've raised it previously, is how does our, I use the word failure to spend our CapEx actually impact upon patients' lives? And carrying forward 2 mil is not an insignificant amount of money, which means there are not machines going ping, fixing people. You know, it is a worry from my perspective, but is my worry founded on anything, or am I just really, this is just better heaters or a better filter water system or something, you know?
So a large portion of that 2 million that's been carried forward is to do with NECAR and the demolition of the Mossy building, and sort of deferred capital projects being brought forward, which is largely sort of infrastructure based. So no sort of
not really
things that go beep and ping.
Yep.
Tend to get bored, especially if they're getting towards the end of being able to beep and ping. They tend to get more pressure on. The reason why we're carrying forward more than usual is not only COVID-19 and not being able to buy things in the last, in the second 6 months of the year, but in the first 6 months of the year, we were late getting the capital program agreed. We were late getting our budgets done, and then we got into the change over in boards, so it didn't get signed off until late. So
we're well ahead now, aren't we? We're not in that same pattern. We're not going to repeat that, are we?
No. We're much faster this year on budgets and things. So yeah, here we are in August. Hopefully you will approve this, and we can move on and get a lot of this done in this 12 months, because there's a lot of things in there that, while not critical that get done today or tomorrow or the day after, they absolutely are priority areas that we've agreed with our clinicians are the things we absolutely need to get done this year.
And the constraint last year's approval was around the capital investment committee sort of coming back to us as to what we put forward for proposals and what we were going to get back out of that.
Are you feeling confident that this will be will fly through with them?
No, they don't.
They don't see this. No.
That was what was last year. There was money made available from government for a lot of sort of infrastructure and catch-up projects, and we got. What did we get? We got $3 million to pull down the Morris Adair building, and anything left over from that to do capital investment stuff. So some of that is carried over from that, and we got $5 million for a child and youth hub, and
about 20,
and the $20 million for the mental health and addiction facility.
Come here's a question.
Effectively, we put up about a total of about 46 million of capital projects outside of our free cash from depreciation. So we've effectively got 23 of them.
28.
Okay, come.
Less of a question and more of a couple of comments. Thank you for just underlining, Jim, that the clinicians have been involved in prioritising our capital spend. I think that's a really important thing for the board to understand. And secondly, although we are being asked to approve a capital budget that's actually a bit more than our sort of cash availability, I think our what I'm hearing is assurance that this is manageable within the balance of the financial year, and we do actually have a basically a reasonably established pattern of some carry forward each year. So I just wanted to say that I'm comfortable with this.
Anyone else?
I just had one query. I wondered the bronchoscope was that piece of machine that wasn't here. Now we've got one.
Or getting one.
I'm not sure about that, Meredith. Yeah.
See it listed in the items.
Well, I think a bronchoscope goes actually goes down into people's lungs.
Oh, I
see. So you may be referring to a piece of equipment that only goes a little higher than that. Yes. No, so I don't think it is.
Okay.
That just raises, following on from that actually, is the list of building and engineering works. that being brought forward, but at what point do you put a bit of, stake in the ground and go, we're doing that? Thinking in terms of summer's coming and we've got air conditioning awards on the list, and I know it's been a thing for a long, long time. So when do we actually say we're doing air conditioning awards or we're doing the refit?
So air conditioning is happening now. We've done Ward 5 as a trial ward that was endorsed by Tairāwhiti, and we're moving that through the clinical areas within the DHB. We've just put in a picture of the balance of 36 units. I've already had, I think, 9 arrive on site, so they'll be kicking off as soon as we get the back boards made for those, so they'll be rolling out.
Are they installed by local companies?
They are, yeah. So a mix of our guys on site.
I guess my question being, where they came to continual rollovers, like getting rid of all the flat roofs, well, that's going to be a major. So is this a year's work is what I'm asking, or is this a year plus one type work program?
So a lot of that sort of, as soon as we came out of lockdown, when level 4 lockdown lifted, so the guys were able to start getting pricing and working through those. So they're well advanced at the moment.
I guess there's 2 things I'd say, but there are 3 things. One is that, some of those things help to stimulate the local economy, but then, of course, everybody's stimulating the local economy. So, we may not necessarily be able to get people to say, come and do this, as opposed to many of the other things that people are wanting to do. And I just, in that building and engineering thing, you'll notice that the word greenstone is mentioned quite often. So, can refer to before, it's our site master plan and the work that we had done probably about 5 or 6 years ago now on the site master plan about what we needed to do on this site going forward. So you'll hear more about that when we have the session on that, but that's some of those things coming through that we're advancing there.
Thank you.
Anything else? So are we happy to adopt that figure? General consensus?
That's good.
Done. Okay, next on the list is the Hiwa Etarangi terms of reference. People have read them. Are we happy to adopt the recommendation to sign off the terms of reference? I like your nodding now. Okay, done. Okay, now we are moving into the section to exclude the public. Do we need to do anything?
Yeah, we need to. You true that.
What I usually do is formally move that we move into the public excluded session.
Okay.
Okay.
We formally move into it. Yep.
Seconded by Andy.
Thank you. Right, tell me when we're ready to roll.
All that stuff you don't know about.
I'm just emailing Dave now.
Can I just once again, while we're still live, just on behalf of the board, say thank you to those who have joined us. I had a quick look on YouTube and we've had lots